Hello, my name is Donna Volpe, and this is my intervention study on the Zika virus. A little bit of background and how the Zika virus is in itself a public health burden. The Zika virus is a member of the virus family Flavividae in the genus Flavivirus and is transmitted by mosquitoes who act as vectors for this disease. There are two types of Aedes mosquitoes that are capable of transmitting the Zika virus. The first is the Aedes aegypti mosquito, and the second is the Aedes albopictus mosquito. These mosquitoes also transmit chikungunya, dengue, and yellow fever. They're found in warm climates and breed in standing water. The virus can be transmitted from a pregnant mother to her fetus through blood transfusion or through sexual contact. Further study is really required to better understand these potential modes of transmission. Recent reports, however, from Brazil of the Zika virus being found in saliva, breast milk, and urine also require further study to determine whether these can be sources of transmission as well. It's interesting to note that most of the infected people remain asymptomatic, and that's approximately 80% of the people contracting the Zika virus. The disease symptoms are usually very mild, and the disease is usually characterized by flu-like symptoms, such as a short-acting fever of 4 to 7 days duration. Microcephaly and other fetal malformations based on preliminary research have been associated with the Zika virus. Microcephaly, or small heads on newborns, can result in severe brain damage. Microcephaly is actually defined as a head circumference measurement that is smaller than a certain value for babies of the same age and sex. This measurement value for microcephaly is usually less than 2 standard deviations below the average. This condition can also be diagnosed by an ultrasound, but most South American countries where the virus is prevalent ban abortion and even contraception. Microcephaly is not curable. So I've talked a little bit about the disease, its symptoms on there. What really brought about this burden that really came to light was this unusual increase in microcephaly noted during a recent Zika virus outbreak, both in French Polynesia and in Brazil. In 2014, there were 147 cases of microcephaly reported. In 2015 to now, Brazil itself has had over 4,000 suspected cases of microcephaly, with so far 270 confirmed evidence of this infection. The clusters of cases appear to coincide with the regions where the Zika virus is most active. Early reports of cases in Brazil seem to indicate that many of the microcephaly cases are on the more severe end, with some of the babies being born having died as a result of a miscarriage or shortly after birth. With this causal link, there is a public health burden of this disease on pregnant women, especially those in poor cities with no air conditioning, inferior sanitation, or lacking simple window screens. This mosquito is prone to areas of standing water, and it's known to be a day biter. The vector can also be found in regions from southern USA to northern Argentina, which is an area in itself that encompasses about 500 million people. The World Health Organization estimates that there will be between 3 to 4 million cases of the Zika virus infection in the Americas in the next 12 months, based on dengue dynamics in that region and Zika virus infections in Brazil. This is especially concerning because Brazil, being the most populous South American country, it also has a high birth rate of about 15 per 1,000 women. So this is something that's very concerning as a disease. Other things to note that contribute to the burden are the 2016 Olympics are scheduled to be in Brazil. But with what's being said now, people are weary of traveling to this country, women of childbearing age, as well as men. Estimated costs of the Zika virus are $3.5 billion in 2016, and this was based on a article by Zagorski in 2016. Some epidemiologic data. In 1947, the Zika virus was first identified in rhesus monkeys. By 1952, the virus was first identified in humans in Uganda. In 1968, it was identified in Nigeria. It's important to note in here that when it was first identified in Uganda, it had a prevalence rate of about 6.1% with 99 confirmed cases. In Nigeria in 1968, it had a 31% prevalence rate. By the time 2007 in Micronesia, there was a 73% seroprevalence rate with 185 confirmed cases. Before 2007, the areas with reported Zika virus included just tropical Africa and Southeast Asia. There were very few outbreaks documented prior to 2007. An outbreak that was reported on Micronesia from April to July 2007 was really the first outbreak of the Zika virus identified outside of Africa and Asia. Between 2013 up until now, several significant outbreaks have been seen on islands and archipelagos from the Pacific region, including a large outbreak in French Polynesia. This is an epidemic curve of countries and territories reporting the Zika virus transmission from 2012 to February of 2016. In 2015, the Zika virus emerged in South America with further spread across the Americas. Currently, it has been confirmed in 52 countries and territories. Risk factors for the Zika virus include the global traveler. So these people traveling to these countries that are known to harbor the mosquito. Spouse or significant other being global traveler. We suspect that the Zika virus may be spread through sexual transmission. Climate changes and warming temperatures. This mosquito enjoys a warm climate. Socioeconomic conditions and poverty. Certainly living in a slum-like area or a home devoid of air conditioning or window screens is going to subject that person to a risk factor of developing the Zika virus. So current studies, a 2016 retrospective study by Cochemez et al. Analyzed data from the Zika virus outbreak in French Polynesia. So the Zika virus outbreak began in October 2013 and ended in April 2014 with 66% of the general population infected. That gives a confidence interval of 95%. 8 microcephalic cases were identified during the 23-month study period. 7 or 88% occurred in the 4-month period of March 1st to July 10th, 2014. The timing of these cases was best explained by a period of risk in the first trimester of pregnancy. In this model, the baseline prevalence of microcephaly was 2 cases with a 95% confidence interval per 10,000 neonates, and the risk of microcephaly associated with the Zika virus infection was 95 cases per 10,000 women infected in the first trimester. Targeted case definition, or my specific risk factors. So for this study, I'm looking at patients with a rash with 2 or more of the following signs or symptoms: fever, conjunctivitis, joint pain, pain in the muscles, or periarticular edema, as well as those who have laboratory confirmation of the Zika virus. The objective of this study is to investigate the incidence of 2 or more case definitions associated with the Zika virus during pregnancy and their correlation to microcephaly using a case control design. Study design and methods. This is a community-based study, and it will be a case control design of mothers who deliver their babies at a 212-bed hospital. After enrollment, a questionnaire will be administered in a face-to-face interview to obtain information on demographic characteristics and signs and symptoms. Cases are the mothers who delivered a baby with microcephaly. Mothers and infants will be tested for the Zika virus. Controls: mothers who did not deliver a baby with microcephaly. Mothers and infants will still be tested for the Zika virus. Study intervention will be testing for the Zika virus, as well as counseling for the care of an infant that is diagnosed with microcephaly. The study setting is a maternity department of 215-bed Catholic Medical Center located in the Lehigh Valley area of Pennsylvania, servicing a primarily Hispanic clinic population. The sample size will be mothers who deliver their babies at that 215-bed community hospital from May 1st, 2016 to December 31st, 2016. Measurements. Data measurements of the study will include a medical records review and a standard questionnaire applied in a face-to-face interview to collect information about demographic statistics, signs and symptoms, and the duration and severity of the illness. Based upon this information and the delivery of the newborn, lab testing will be conducted to confirm the presence of the Zika virus as a secondary outcome. The independent variables were to identify statistical associations using regressive logistic bivariate models. Variables identified with p-values less than 0.1 will be considered. Risk rates will be adjusted with their respective 95% confidence intervals, and those will be analyzed. My variables. So controlled variables will be the face-to-face interview. Independent variables include the demographics, race, mother's age, gravidaparity, visits to countries known to have the Zika virus, spouse, significant other who have traveled to countries known to have the Zika virus. The dependent variable will be the head circumference of the newborn. Anticipated outcomes are to identify the signs and symptoms which may predict the presence of the Zika virus, and to provide a quantitative estimate of the risk of microcephaly in fetuses and neonates whose mothers are infected with the Zika virus. Other anticipated outcomes include that these outcomes may suggest that the virus can cross the placental barrier. The study cannot prove the Zika virus causes babies to develop microcephaly, but can show an association. And the findings may support the need for a prompt response to protect, inform, and monitor pregnant women. Study strengths. As a case control study design, this research will describe observations. The findings will add to the body of evidence in this study and provide a route for further research. Limitations of this study include more epidemiological evidence is needed that looks at groups of pregnant women with and without the Zika virus to rule out other factors, such as perhaps fetal alcohol syndrome, environmental factors, or other types of infections. The sample size will be limited as this hospital has an annual birth rate of about 400 women. A history of a nonspecific rash during pregnancy is subject to recall bias and might have resulted in misclassification of potential Zika virus exposure. The Zika, dengue, West Nile, and chikungunya viruses all have similar signs and symptoms, and 80% of the Zika virus cases are actually asymptomatic according to the CDC. Here are my references. And thank you for your time.